Hi, this is Divya Prakash from nuclearmedicinSolutions.in. This is the fourth video of nuclear medicine dose assessment series, and in this video we are going to discuss about the MIRD formalism. In the last three videos we have discussed nuclear medicine dosimetry, the future's essential need, nuclear medicine dosimetry, the stakeholders, and in the third video the name was changed from nuclear medicine dosimetry to nuclear medicine dose assessment. And in that video we discuss the mathematical part of nuclear medicine dose assessment, and we saw how to calculate absorbed dose. In this video we are going to discuss about MIRD schema. When I say MIRD schema, there are a number of questions comes in my mind, and the question is why MIRD was needed and what is this schema? What are the historical changes took place in MIRD technique? What are important MIRD publications? How the S value is calculated, because MIRD schema is known for the S value of absorbed dose calculations. So how that S value is calculated, that we are going to see in this presentation. We will see a brief discussion on different generations of phantoms used for S value calculations. We will be seeing what are the targets and source organs are used in MIRD, and we'll also see how do we scale S value for true mass, because MIRD uses fixed phantoms masses of organs. So if we are going to do a patient individualized dose assessment, then how can we scale that to a true mass? That we are going to see in this presentation. We are going to see the strength and weaknesses of MIRD schema. We are going to see the applications of MIRD schema, and finally we are going to see how the dose calculations can be done using MIRD schema and what are the essentials are required for accuracy of this dose calculations. So let's find out the answer of all these questions and begin about what is MIRD and why this was needed. To find the answer of these questions, we'll have to see a little bit a revision of last presentation, where we saw the absorbed dose calculations formula and we saw the real life dose assessment, what all the things are required to calculate dose assessment. The details of all these slides are given in previous presentations, so please watch those videos if you wanted to see the detail of these slides. We saw this example where we calculated absorbed dose using delta beta time integrated activity, and finally we got the absorbed dose as 6.79 millirad. In all these calculations we made certain points to note, and those points are absorbed dose calculations having contributions from penetrating radiation as well can be quite tedious, especially when there are multiple emissions. This problem was simplified by introducing a factor which accounts for all other components except time integrated activity. There are different systems name this factor with the different names with little variations, and those names were S factor by MIRD group, specific effective energy, that is C factor by ICRP, and the dose factor by radar group. The MIRD system is developed by a committee within the SNM-MI, which was formed in 1965 with a mission to standardize internal dosimetry calculations, improve the published emission data, and enhance the data on pharmacokinetics. This provides framework for calculation of absorbed dose to a certain region. The absorbed dose is a product between time integrated activity A tilde and the S value. The formula is D is equal to A tilde into S, and this S value includes the energy emitted E with its probability Y the absorbed fraction phi, and the mass of the target organ m. The ICRP, that is International Commission on Radiological Protection, which began in 1928, emphasizes mainly about radiation protection of occupational workers and members of public, although not exclusive as commonly misbelieved. The ICRP system uses the symbol H, which is the equivalent dose, and the formula is H50T is equal to sigma S U50S into C factor, which is from source to the target. All these details, what is 50, everything has been explained in previous videos. And the radar group, that is Radiation Dose Assessment Resources Task Group, which is of SNMMI, devised a similar expression of dose equation, and the formula is dt is equal to sigma s ns into df from source to target. This ns is the number of integrations per second, and its same a tilde converted into dps, and df contains the rest of the terms of absorbed dose formula with the unit gray per dps. Now let's see MIRD in detail. As an overview of MIRD, this provides a broad framework for assessment of absorbed dose to whole organ, tissue subregions, voxelized tissue structures, individual cellular compartments, and this is used for both in diagnostic and therapeutic nuclear medicine. The schema was originally published in 1968. It was revised in 1976. It was republished in most well-known form with comprehensive examples as MIRD primers in 1988 and again in 1991. In 2009, MIRD published another document which standardized nomenclatures, formally adopted equivalent dose and effective dose, identified dosimetry quantities for deterministic effects relevant to targeted radionuclide therapies. So let's see what are the important publications of MIRD. In 1968 and 1976, the first publication of pamphlet 1 and the revised, they were published. In 1975, S value for many radionuclides were published in pamphlet 11. In 1988 and 1991, MIRD primers were published. In 1999, S value for voxel sources were published in pamphlet 17. In 2003, in pamphlet 19, radionuclide S values for 6 age-dependent multi-region models of kidney was published. In 2009, a generalized schema for standardization of nomenclatures was published in pamphlet 21. In 2015, they published pamphlet 25, which was MIRD Cell version 2.0, a software tool for dosimetric analysis of biological response of multicellular populations. And the last publication came in 2016, which was Joint EANM MIRD Guidelines for Lutetium-177 Dosimetry, and that the publication was pamphlet 26. In 1975, the equation of MIRD was DRK is equal to sigma H A tilde H into S RK back arrow RH. This K and H both are in suffix, where RK is target organ or region, RH is source region. The use of subscript H and K for source and targets and not having S and T was unusual. Let's see the story behind keeping subscript as H and K for source and targets. The early work done with this system was done by Fortran programmers. In the old Fortran, integers which were used as looping indices began in the alphabet with the letter I. So the letter I and J had already been taken, so the other variables H and K were used. In 2009 of latest publication of Formalism, which was published to bridge the differences in the formalism used by MIRD and ICRP with three objectives. The first was to restate its schema for assessment of absorbed dose in a manner consistent with the need of both the nuclear medicine and the radiation protection communities, with the goal to standardize nomenclatures. The second objective was to formally adopt dosimetry quantities, which are equivalent dose and effective dose, for use in comparative evaluations of potential risk of radiation induced stochastic effects. And the third objective was to discuss the need to identify dosimetry quantities based on absorbed dose that addresses deterministic effects relevant to targeted radionuclide therapies. And the formula was DRT T is equal to A tilde RST into S RT back arrow RS T. And this gave formulation for absorbed dose to a target region RT at time T from activity contained in a source region RS. A tilde RS is total number of nuclear disintegrations in the source region that have occurred up to time T and is known as the time integrated activity. S is radionuclide specific quantity representing the mean absorbed dose rate to target tissue RT at time T after administration per unit activity present in source tissue RS, and it is known as S factor and relates the absorbed dose in the target region RT to the time integrated activity in source region RS at time T. So what is S value? S is the characteristic of radionuclide and anatomical models which are age and sex specific, chosen to represent the patient or tissue of interest. Alternatively, the model may be based on segmented images of subject anatomy from either CT or MR images. The source RS and the target RT are defined within the anatomical models and may represent the full range of configurations. And these configurations includes whole organs, suborgan tissues, voxels, tumors and cell clusters, individual cells or cell components. Means we can calculate the dose assessment of these all the configurations. And the formula for S value is sigma I EI YI phi RT back arrow RS EIT divided by M RT at time T, where EI is mean or individual energy of ith nuclear transition, YI is number of ith nuclear transition per nuclear transformation, phi is absorbed fraction, and M is time dependent mass of the target tissue RT in the reference individuals. In practical nuclear medicine dosimetry calculations, the S factor is a previously calculated entity for combination of RT and RS and for photon and electron energies separately. So this is the table which was given by MIRD pamphlet 19, and they have given the values of suborgans like kidney, cortex, medulla, pelvis, papillae, trunk, and they have given different energies for photons as well as electrons, and the different energies they have calculated is 0.01, 0.015, 0.020. Like this, with the different energies they have calculated the values. These values I have not shown because this is the copyright material and this is the free to download material, and the reference for the same is shown in the slide. So anyone can visit the SNMMI website and they can download these values and they can get it easily. They have calculated for different radionuclides also. See 11C, 13N, 15O, like that they have calculated S value for different radionuclides with different suborgans. So let's see how this S value is calculated. The source and the target regions are a specified organ or tissue or suborgan entity including cellular compartments or a voxel. The S value calculated for each organ means with respect to each organ, like lung to liver, liver to lung, liver to kidney, kidney to liver, with all these from one organ to the with respect to the other organ, or within the suborgan entity or a tissue or a cellular compartment, they all have given this all the source and target regions. This activity spatial distribution throughout the source region RS is assumed to be constant. A Monte Carlo code is used to simulate the radiation transport from the radionuclide in source RS to the target region RT. The individual energy deposition in the target regions are then summed and normalized to the mass of target region, and such calculations are immensely computationally intensive. So we are done with the first 5 questions, and we are going to see the next 5 questions, that is, which are all the target and source organs used in MIRD, how can we scale S value for the true mass, what are the strengths and weaknesses of MIRD schema, what is the application of MIRD schema, and how can we calculate dose using MIRD schema, and what are the essentials for accuracy of these calculations. So let's see one by one. In this slide we are going to see what are the source regions and what are the target regions. There are 26 source regions are defined and there are 24 target regions in MIRD schema. 25 of these source regions are specific tissues or organs, are the contents of organs, and all other tissues are grouped into a remaining tissue category. In the target regions of 24, the whole body is noted as being a target region, and the S factor for the whole body yield the absorbed dose to the whole body, that is total energy absorbed by the body divided by whole body mass, and it should not be confused with the effective dose, which is a stochastic risk weighted sum of organ absorbed doses. So let's see the source regions and the target regions. Just see, this gallbladder contents is the source region and the gallbladder wall is a target region. This urinary bladder contents is the source region and urinary bladder wall is the target region. Likewise, all other organs are clubbed as a remaining tissues, and here the target region is taken as a whole body. So let's see what all the models were used for calculation of S value. The first models which were used were analytical phantoms, and anatomy was described by analytical equations with spheres or cylinders placed in the coordinate system to represent structure of the anatomy. And there were several anatomical phantoms like adult man, non-pregnant female, pregnant woman for each trimester of pregnancy, children from the newborn and up to 15 years of age, as well as models of the brain, kidney and unit density spheres. The second generation of phantoms were voxel based phantoms, and they offered the possibility of more detailed models of anatomy, and they can be based on the segmentation of organs from tomographic image data such as CT images. In the third generation of phantoms, they were created using non-uniform rational spline, that is NURBS. NURBS is mathematical model used in computer graphics to represent surfaces, geometrical shapes and free form with the same mathematical representation, and the surfaces are flexible and can easily be rotated and translated. They can have movements in time, that is breathing and cardiac cycles can be included, allowing for 4D representation of phantoms, and anatomical phantoms for calculation of S value for use in preclinical studies on dogs, rats and mice have also been developed and calculated. So let's see what absorption values has been taken for calculation of S values. The common assumptions has been taken for penetrating radiation. For example, electrons, it is taken as 0, and for non-penetrating radiation, for example photons, the phi is taken as 1. The drawback of this system is it is oversimplified, and the validity of this depends upon the energy of radiation and the size of the source organ, which is to be assessed on a case-to-case basis. The electrons which has phi more than 0.9, if the mass of the unit density sphere is more than 10 gram and the electron energy is less than 1 MeV. As the mass decreases, the approximation ceases to be valid, and if the mass of the sphere is less than 100 grams and photon energy is more than 50 keV, the phi is less than 0.1, and as the mass increases, the approximation becomes inappropriate. Now let's see how the S value can be scaled for true masses. To adjust the S value tabulated to the true mass of the target region, the S value can be scaled by mass according to, this is the formula for the calculation of S value. So here the mass of the tabulated is divided by mass of the scaled. So the point to note is phi is considered to be constant in the interval of scaling, so the change in S is set equal to the change in mass. The recalculation of S value can be more accurate by separating the total S value for penetration and 1 for non-penetrating radiation, and this is the formula by which S value can be recalculated. It is assumed that phi for non-penetrating radiation is 1 and phi for photons are relatively constant, so SP can be scaled by mass, and this is the calculation for how to calculate S value for the true mass. The phi for photons and electrons vary according to the initial energy and the target volume or mass, so the suitability of recalculation will also vary. Let's see what is the principle of reciprocity. Means S value is approximately the same for a given combination of source and the target region. That is, if the S value for liver to kidney will be almost equal to S value for kidney to liver, and this is valid under ideal conditions like regions with a uniformly distributed radionuclides within a material that is infinite and homogeneous or absorbs the radiation without scatter. Although the ideal conditions are not present in the human body, the reciprocity principle can be seen in S value tables for human phantoms, as the numbers are almost mirrored along the diagonal axis of table. So what are the strengths and limitations which are inherent in the formalism? To understand the strength limitations, we need to understand what are the basic assumptions of MIRD formalism, and there are two assumptions which are the uniform activity distribution is there in the source region. So it is the first assumption of MIRD is the activity distribution is uniform in the source region, and the second assumption is that it is calculated for mean absorbed dose to the target region. So the strength is its simplicity and ease of use, and the weakness is absorbed dose may vary throughout the region, whereas it is considered as uniform throughout the region. So there is a chances that there will be lot of errors in the calculation. Let's see what are the application of MIRD formalism. The applications are different for different purposes, and that depends upon different levels of accuracy. Like for diagnostic procedures of nuclear medicine, the accuracy demand is different. For therapeutic nuclear medicine procedures, the accuracy is different, and for accidental intake of radionuclide, we need a different level of accuracy. So depending upon different purposes, their applications are different. For diagnostic procedures, the aim is to optimize the procedure concerning radiation protection consistent with accurate diagnostic test. Means the mean pharmacokinetics for radiopharmaceuticals should be utilized for the calculation of time integrated activity and S value based on reference man phantoms, because the radiation amount which is used in diagnostic nuclear medicine is a very low quantity. So if there are errors in the calculations, this can be easily avoided. But for therapeutic nuclear medicine, the aim is to optimize the treatment so as to achieve the highest possible absorbed dose to the tumor consistent with the absorbed dose limiting toxicity. And they recommend individual treatment planning should be performed that takes into account the patient specific pharmacokinetics and biodistribution of therapeutic agents. The dosimetry in case of accidental intake of radionuclide. Here the procedure is to apply after an accidental intake of radionuclide must be decided on a case-to-case basis, and that depends upon level of activity, radionuclide, number of persons involved, retrospective dosimetry, or as a precaution, possibility to perform measurements after the intake. So let's see how to calculate absorbed dose using MIRD formalism. The equation for absorbed dose in MIRD is D is equal to A tilde into S, and this S value can be seen in tables for organ labels, sub-organ labels, voxelized tissue structures, and individual cellular compartments. So we just need to calculate this A tilde, and that is time integrated activity, and we have ready to use S values. Simply we multiply and then we can get the value of absorbed dose D. So the calculations of A tilde can be done using 2D or 3D images. In 2D images, whole body scans or spot views covering the region of interest can be used. In 3D spec, limited field of view including the essential structures of interest can be imaged, and then the activity can be calculated. In 3D PET, which has a greater ease and accuracy of radio tracer quantification, they can also be used. And this 3D tomographic methods avoids problems associated with corrections for activity in overlying and underlying tissues. For example, muscle, gut and bones, and corrections for activity in partly overlapping tissues, for example liver and the right kidney. So what are the essentials for accuracy of dose assessment? In order to calculate time integrated activity on an organ level or a voxel level, please ensure there is a registration of images and the acquired number of counts per organ or voxel. The random errors should be avoided. The calibration factors, that is number of counts to activity, random or systemic errors should be avoided, and attenuation corrections should be done properly. The multimodality imaging such as SPECT CT or PET CT facilitates the interpretation of images, as the CT will provide anatomical landmarks to support the functional images which could change from one acquisition to the next. So to calculate A tilde, there are different methods which are used, like dose point kernels, which describes the deposited energy as a function of distance from the site of emission of radiation, and they use convolution of a dose point kernel and the activity distribution from an image acquired at certain time after the injection gives the absorbed dose rate. It provides a tool for fast calculation of absorbed dose on a voxel level, and the main drawback of DPK is it is only valid in a homogeneous medium where it is commonly assumed that the body is uniformly unit density soft tissue. There are Monte Carlo simulations are used, which uses the activity distribution from a functional image, that is PET or SPECT, and the density distribution CT, avoiding the problems of non-uniform media. The full Monte Carlo simulations are time consuming, and there are different simulations like EGS, that is electron gamma shower, MCNP, that is Monte Carlo, N particle transport code, Gint and Pentelope are commonly used Monte Carlo codes. Dose volume histograms are used, which are extensively used in EBRT and can be used to display non-uniformity in absorbed dose distribution from radionuclide procedures. Differential DVH and cumulative DVH can be calculated. A truly uniform absorbed dose distribution would produce a differential DVH that shows a single sharp delta function peak and a step function on a cumulative DVH. In the next presentation, we are going to see equivalent dose and effective dose and their use in nuclear medicine dose assessment, where we'll find the answer of questions: what are equivalent dose and effective doses and their use in dose assessment, why MIRD did not adopt these quantities for so long. They have adopted this in 2009, so why did they not adopt till 2009? That we are going to find the answer. We are going to find the answer for: are they useful in diagnostic nuclear medicine dose assessment or therapeutic nuclear medicine dose assessment, or it is used for both? Are they used for stochastic effect or deterministic effect, or for both? And if not, which are the terms used for these effects? These are all the references which has been used in making these presentations. So thank you for your patient hearing. Please feel free to write us at support@nuclearmedicinesolutions.in for any feedback or query. You can also suggest your topics of your choice which you wanted to be addressed. Thank you very much.